Guideline for the management of patients with acute coronary syndromes. Top take-home messages. Dual antiplatelet therapy in ACS. DAPT is recommended for all ACS patients to prevent thrombotic complications. Ticagrelor or prasugrel is preferred over clopidogrel in patients undergoing PCI due to superior efficacy. In non-STEMI patients scheduled for invasive management, 24 hours until angiography, early initiation of ticagrelor or clopidogrel may reduce major adverse cardiovascular events. DAPT duration and bleeding risk reduction strategies. Standard duration. Aspirin plus P2Y12 inhibitor for at least 12 months, unless high bleeding risk is present. To reduce bleeding risk, 1. Proton pump inhibitor, PPI, recommended for patients at risk of gastrointestinal bleeding. 2. Ticagrelor monotherapy after 1 month of DAPT, recommended for those tolerating initial therapy. 3. For patients requiring long-term anticoagulation, aspirin should be discontinued 1 to 4 weeks post-PCI with continued P2Y12 inhibitor use, preferably clopidogrel. Lipid-lowering therapy for secondary prevention. High-intensity statins are first-line therapy for all ACS patients. Atorvastatin 40 to 80 mg, rosuvastatin 20 to 40 mg. Ezetimibe may be initiated concurrently with a statin for additional LDL reduction. If LDL remains 70 mg daily despite maximally tolerated statin therapy, a non-statin lipid-lowering agent, e.g., ezetimibe, evolocumab, alirocumab, inclisiran, bempedoic acid, is recommended. For very high-risk patients, LDL 55 to 70 mg per deciliter despite therapy, intensifying lipid-lowering treatment may be reasonable. Invasive management of non-STEMI patients. For intermediate high ischemic risk, an invasive approach with the goal of revascularization is recommended during hospitalization to reduce MACE. For low ischemic risk, a selective invasive approach with risk stratification is recommended to determine the need for revascularization. Procedural strategies in PCI for ACS. Radial artery access is preferred over femoral access in PCI procedures to reduce bleeding complications, lower vascular access complications, decrease mortality risk. Intravascular imaging, IVUS or OCT, is recommended to optimize PCI outcomes in patients with complex coronary lesions. Complete revascularization strategy in ACS. For STEMI or non-STEMI patients, complete revascularization is recommended. Choice of strategy. Coronary artery bypass grafting versus multivessel PCI should be based on coronary anatomy complexity, comorbid conditions. In STEMI with multivessel disease, non-culprit lesion PCI can be performed either during the index procedure or as a staged approach. Preference for single procedure multivessel PCI when feasible. In ACS with cardiogenic shock, immediate PCI of the culprit lesion is recommended. Routine PCI of non-infarct-related arteries at the same time is not recommended. Use of microaxial flow pump in cardiogenic shock. Reasonable to use in select AMI-related cardiogenic shock cases to reduce mortality. However, complications are higher than with standard care, including increased bleeding risk, higher rates of limb ischemia, greater likelihood of renal failure. Careful vascular access and early weaning of support are crucial to balancing benefits and risks. Red blood cell RBC transfusion in ACS and anemia. Transfusion to maintain hemoglobin at 10 grams is reasonable for ACS patients with acute or chronic anemia who are not actively bleeding. Has secondary prevention after discharge. Fasting lipid panel recommended 4 to 8 weeks after initiating or adjusting lipid-lowering therapy. Cardiac rehabilitation is strongly recommended, with an option for home-based programs for patients unable or unwilling to attend in person. Adapted from the 2025 ACAHA AIMS-P SCAI Guidelines for the Management of Patients with Acute Coronary Syndromes.